start off with some sort of insider's perspective on COVID's impact in hospitals. Dr. Young will be made a gorgeous presentation and we'll be presenting that. And then we'll go into some of these myths that we chose, and they're very cool. We did like an Instagram preview and we got 60-40 on like true or false. So these myths are pre-tested and they are kind of confusing. So don't be afraid to get any of them like wrong. And we will be asking like our professional here what exactly is going on with them. And obviously, while we do have Dr. Young with us, we will like to just give everybody an opportunity to give their questions and then get answers. So without further ado, welcome to our event. And we're ready when you are, Dr. Young. Thank you.
Right, perfect. So should I share my screen now then? Okay, great. Let me make sure I do this right. There we go. So you can see the PowerPoint. So let me just make sure it actually comes up as the PowerPoint. Is it coming up full screen now? All right, perfect. So good evening, everybody. Thank you for attending, and thank you, Meilin and Jeremy, for asking me to be part of this event. So to say the least, the pandemic has ripped through our world and through like a multinational aspect from in more ways than one. And a lot of you guys probably had some personal, like individual family members or even loved ones either succumb to the disease or at least contracted disease and actually have to face long-term outcomes for it. So I think part of the main reason why is as a younger population, as you guys all know, you become the backbone of your family members, like especially your huge support system for your parents, grandparents, etc. And I think a biggest thing is just there's a lot of misconception for the disease itself and in terms of everything that surrounds the disease. So part of this hopeful presentation is just to be very broad and generic about just COVID in general, a little bit of what we see on the inpatient hospital side and what we've seen a little bit on the outpatient side. And then we'll dabble a little bit into the vaccines too. So brief introduction, I am one of the pulmonary critical care physicians at Allegheny Health Network, hence the background. I am also one of the lead physicians for our post-acute COVID syndrome for the network itself, with my office predominantly down in the South Hills, but I do have a lot of partners who also help cover the North Hills and everywhere else within the network too. Little bit of an outline, just going very briefly for the numbers. So it is a little outdated just because every single day there's always a mortality, there's always more positive cases. So my numbers are actually extrapolated from just yesterday. A little bit on the manifestations, the management that we do from both inpatient and outpatient, the long-term effects, because as with media and social media in general, you've probably heard of the diagnosis of brain fog and like this post-acute COVID syndrome or the long haulers, and then a little bit on the vaccinations too out there. So total cases that have been recorded since the first discovery in the United States as of last year is around 33 million, with the total deaths almost already reaching 600,000. And the total deaths, I always tell patients to take with a grain of salt, just because there's probably a lot more cases that have been underreported just because either the location didn't have the proper testing quite yet when the disease was first discovered. And there's already cases tracing back as early as October 2019 that potentially touched ground in the United States. So you can imagine if patients were already dying from a respiratory standpoint, it could have already been due to COVID. We just didn't have the ability to test it yet. There are actually a lot of variants. So for a lot of the Greek buffs, you have alpha, beta, gamma, delta, and epsilon. So the most prevalent strain that we'd had was the original one, and that's actually where our vaccines were based off of. But since then, we know everything goes through mutation, especially for viruses. It's very quick and rapid. So the one that had the most boom recently that Dr. Fauci, the president, and everyone's worried about is the Delta variant, which is the B1617.2. The numbers just basically has a little change in the structure, but the overall core of the virus is still the same. The biggest danger about all of these variants is the fact that it's more easily transmissible. So before, it's potentially like the N factor was potentially like one person is the person who has it and could affect, for example, like 4 to 5 people. They've noticed that this can infect more and more rapidly too. So manifestations of symptoms we've been noticing have been a lot quicker too. And it's spreading a lot more. And there's about 10% of the US population who's currently reporting positive for COVID have the Delta variant. And that's kind of important only because when we touch on vaccines, we've noticed that these variants also decrease the efficacy of our vaccines as well. So that's one of the biggest concerns we have right now is we might be seeing more positive cases even in vaccinated patients, but not necessarily as severe as before. So the total vaccine administration is for at least one dose, either the Pfizer, Moderna, or even including the single dose Johnson & Johnson is around 65.4%. And part of it is what's important is based on historical data, roughly around 70% of the population of actually being fully vaccinated is where we can potentially achieve what we call herd immunity. So it helps protect a lot of the patients who could potentially not be able to get the vaccines from potentially contracting disease, because you need so much of the patients to actually carry the virus for it to be transmissible and for the virus to actually still exist. So we're almost there, but not quite. This is straight from the CDC. So just looking over at cases that have developed, this data is a little bit old, but they have not updated because it looks like they update it semi-annually. So there should be more information coming around the next few months. But as we kind of expected, there was a huge uptick in the disease itself, end of last year into the beginning of this past year, with predominantly of the elderly population. And we're not too terribly surprised with that, just because they're more susceptible, their immune systems are much more compromised. But if you actually look, when we start swinging into the January, March, April time period, there was a shift in the age range where it's actually more of the younger cases of individuals. So people pretty much around your older brother or siblings age range, if you have family members in their 20s or they're older, or older cousins or older relatives. And the biggest correlation with that is actually because of the vaccination boom that happened for the patients who qualified. So our elderly population were being vaccinated in the early winter time period. And then suddenly we see a huge decline in the positive cases because we knew that they were getting vaccinated. It was likely working. But the older patients, because they ended up not qualifying yet, were the ones that actually contracted disease. Now, the bottom group actually has to do with the deaths. And this is where we're not too terribly surprised. When you're older, you're more brittle. So when you have an 80-year-old person, your grandpa might be smarter than a whip in terms of like comparison to you for mathematics, whatever, but you're still dealing with an 80-year-old body. So a lot of these individuals were the ones who actually succumbed to the disease. But once again, due to vaccinations and even with what we're seeing in the hospital setting, we've been seeing younger patients, like we have 20 and 30-year-olds right now on the ventilator, but not an 80-year-old patient because they were able to get vaccinated already. Now, some of the symptoms, we initially scaled it to common, less common, rare, because COVID was always associated with respiratory symptoms. So you had shortness of breath, a little bit of coughing, runny nose, fevers, loss of taste and smell was actually one of the more prevalent symptoms in the beginning. But then you had some of the rare ones because it can also 20 to 30% of the patients can present with other organ manifestations. And even though this seems very broad, we've actually seen patients with isolated cases of very specific things too, like this. Someone who came in with a stroke happened to be COVID positive. Someone who only had a rash, someone who was only losing their hair, or someone who is only losing or just having some concentration difficulty. We've actually had a few who only had isolated brain bleeds or even a heart attack. So even though majority of the patients came in with respiratory, it's not the only presentation. So I have actually either a name, an age, or a specific patient I have committed to memory who's actually had almost every single one of these at one point in time during the last year. So it's not an all be all. So this is this is just briefly in terms of the treatments. Now I'll dive into this a little bit more just because these are all just names for it, but overall, this is what we have available. And that's just because it's extrapolating from our previous experiences with other diseases and other virus and other infections and using it in the setting of COVID, hoping that it actually works. Now for outpatient, it's all very supportive. For the most part, a lot of these medications that you might see that I have stars to it, the bamlanivimab, oh my God, it's hard to say, etzimumab, remdesivir, baricitinib, it's tongue-tied for those names. But those are very special. Those are for very specific centers who are actually undergoing research and have authorizations. So not every place in the country will actually be able to do it. For the most part, if you're not in the hospital, that means you have a mild case. So it's going to be take a little bit of Theraflu, take some decongestants, over the counters, that sort of stuff to just get you over your symptoms. If you're sick enough, our treatments are helpful, but it's not also very, it's not something that we are going to say it's a cure that you're miraculously going to get better. We just noticed it improves the rate of them healing a little bit quicker, but not necessarily that it's the cure. So steroids that we do, tocilizumab, remdesivir, which are antiviral, and then antibody-based therapies, convalescent plasma, which is actually using the plasma that's from donated individuals with confirmed cases of COVID who recovered. So it's the idea of using somebody else's antibodies to hopefully help fight the infection. Whether or not tocilizumab, remdesivir, and convalescent plasma truly work, from all the studies, it shows it improves mortality somewhat or decreases their length of stay or hospitalization or time on the ventilator is all we have. And because it's so fresh, it's only been 1.5 years. So wouldn't be surprised 5 to 10 years from now, we have all this information data and find out they don't really work. But that is medicine in general. We try whatever we can just to help because we saw so much death with this disease. So this one I want to touch on a little bit more so just because everything that we see on the news, social media, et cetera, we always feel like it's overplaying it because they're always saying, oh, it's not as bad as it really is. It's just accentuated or what's it called, that word? It's just pretty much blown out of proportion because social media, the media just blows it out and it's really not that bad. But quite honestly, from personal experience, it really does get that bad. And I think that was a frustrating part for us on the inpatient side is because we saw people that bad. So it wasn't to the point where we were trying to exaggerate just because we were actually seeing patients getting sicker and nothing we could do about it. So you have your typical oxygen support devices that I always say is non-invasive, meaning we don't have to put a breathing tube down. So a little oxygen delivery by a face mask, a little tube into the nose, Optiflow, BiPAP, CPAP, which is another way of delivering oxygen of flow at a very high rate, either by a mask or a cannula. But if they get so sick, we resort to the breathing tube, which is at that point you're on the ventilator and some life support. And if you fail that and you potentially do qualify, then there's a thing called an ECMO, which is a very, very limited last ditch effort that we have available, where you're essentially taking 2 large, giant garden hose sized tubes into 2 central vessels where you essentially filter blood out through a machine, oxygenate it, and put it back to the body. So if you can imagine, if you're siphoning blood from a patient, even though you're giving it back, there's a lot of complications. Bleeding, biggest one. You can potentially lose the limbs too, which we've seen in place as well. So there's just like a lot of things that we see on the inpatient side that we've had to use and we do use, but we just hope that our patients never reach to that point. So it is a very, very severe disease, and everything that the social media tried to say that a lot of people try to say was an overplay or really was kind of an underplay with what we were seeing. If anything, sometimes I was hoping they were able to even step foot into the hospital just to show what it was like, or for people to actually see what we were seeing and doing. So if you are lucky enough to survive, which even though a lot of people was like, oh, 1.7% mortality rate from COVID isn't really bad, or mortality rate isn't bad. But then there are negating a huge percent of the population who do survive COVID and what it looks like for them. So if you do go into the hospital, you make it out of the hospital, you are potentially looking into having a tracheostomy, which is a tube in your neck connected to the ventilator because you're too weak to have the tube out of you, or you fail to have the tube taken out of you. Then that means you're in a facility for 30 to potentially months of therapy, having somebody literally turning you and taking care of you and you not being able to do anything on your own, even taking a sip of water. If you are on the outpatient side and you're doing okay, and it's just like a little cold symptom, you can have long-term lingering effects. I have so many patients who are like in their 30s and 40s, triathletes, marathon runners, etc., who are still complaining of shortness of breath, even if they're trying to do some dishes, They can't concentrate to do a simple Sudoku puzzle. You can develop heart-related issues afterwards, or you can come in with what we call like a cardiomyopathy, where you're there in heart failure. And that's just from the product of the virus itself causing it. There's a lot of anxiety and depression just because they can't concentrate, they can't work, which means they lose their job, they can't do anything anymore. So imagine for you guys, if you're trying to study for your finals, study for boards or SATs, MCATs, etc., you don't even know what one word means anymore. Or you become slightly dyslexic and you can't even concentrate on that question. So it was life-changing, and it's not just for a couple of weeks, it could linger on for months. And then the fatigue and the myalgias was actually one of the biggest things too, where once again, if you're a marathon runner, or if you like to go jogging and you can't even take 10 steps out the door before you feel like you've already ran a marathon. And it can go on for months and months at a time. So we see a lot of this, even if you're not in the hospital, that if you just happen to catch COVID, you can develop this. And the frustrating part from our side is also 10 people can have COVID, all with very mild symptoms, but all with very different healing processes. Some can get over it right away. 1 week, they're back to normal. We've seen people 6 to 8 months out still having these problems, or it's just a slight slow improvement or recovery period. So it's just not one person is going to be able to tell you, oh, you'll be fine tomorrow, because we just don't know. It could be tomorrow, it could be 3 months from now instead. Now, the biggest thing to help prevent all of this is vaccinations. And this is the biggest thing why we're such huge proponents of it. And I think one of the big misconceptions of it all is probably going to be one of your questions for the fact, true or false, is if I get the vaccine, I can't catch COVID, which is actually absolutely false. You could catch COVID, and the whole purpose of a vaccine, and this is where the papers actually shown the whole efficacy, depending on whichever one you get, from the 80 to the 95% range, is if you do happen to catch COVID, one, you don't have any symptoms and you don't even know you have it, or if you do catch it, it's not severe enough to where you will need to be in the hospital or even see a doctor. You would just feel like, I just have a little cold with a runny nose, I feel fine. And that could have been COVID, but you're protected because that means the vaccine actually worked. So we do have 3 main types, with the 4th one underway and potentially getting FDA approval in the next few months. So you have your mRNA based, which is Pfizer and Moderna. And those were the first 2 that were both approved. And then the 3rd one that came down the pipeline was the Johnson & Johnson one. And then the 4th one down the line is a 14 subunit called the Novavax. There are a ton of other ones out there around the world. There's a Sinovax, or there's a Sino one, the Sinovax one. There's also the AstraZeneca one in the United Kingdom. There was a Coronavax, bunch of different ones from different countries that all have variable efficacy as well. But the best ones, actually, quite honestly, across the world are the ones that we have available in the States. So for us not to capitalize on that is going to be a huge, huge disservice to yourself. But that's my little soapbox on vaccinations. So long story short, get the vaccine. It doesn't matter which one, because it helps prevent you from getting a serious disease. And this is just a quick little thing on our references. I grabbed a lot of the stuff from IDSA and from the CDC. Those are going to be the 2 best resources, specifically the one from the CDC, because it's the most up to date with everything. It provides you with the literature if you ever want to read into it. If you're any like statistically savvy or know how to break apart research articles, definitely read into it, because it will change your perspective a lot in understanding of the disease too. Okay, and that was that. I hope I didn't ramble too much. I try to keep it short just to kind of get in as much information for you guys as possible. So that way we can actually leave some time for like question and answers and stuff too. So let me stop.
Sure. Thank you so much for that. Like, that was super insightful. And I feel like that leads us, especially since you finished on the topic of vaccinations, really well into our next portion, which will be all about busting myths about vaccines. So I'll just share my screen really quickly. And sorry, I have someone in the waiting room. And basically, this is going to be sort of an interactive game-like format, so we can get some audience participation in here. And basically on the screen, you are going to be seeing a myth about the COVID-19 vaccines. And if you feel comfortable, please put, whether you think this is true or false in the chat. And then we will circle back to Dr. Young after we've had some time to think and then get the scoop. So with that, let's get into it.
Our first myth is if I've already had COVID-19 and healed from it and have a certain level of immunity, I don't need the vaccine. So feel free, again, just type in true or false in our chat. And don't worry about being wrong. I know we have like another doctor in this chat, so it might be a little more intimidating. But honestly, see, we're all at it again. So that's amazing. Seems like a good amount of answers. Dr. Young, if you want to reply to those.
Yeah, so everyone pretty much, it looks like it's false, which is everyone is correct. It is false. So even though if you healed from COVID, we don't know how long the antibodies actually last in your system. I actually have my sister-in-law's friend actually contracted COVID 3 separate times after recovering after a month apart. And that just goes to show that we don't know how long natural antibodies linger for. And we do know from the variants that if you've had a history of COVID, if you contract the variant, you won't have the proper antibodies for it either. So the best is going to be getting the vaccine itself because that's going to give you the best immunity. Now, the vaccine, we don't know how long the antibodies we do develop from it actually last for. But so far, the data shows it's at least 6 to 8 months now since its production, and there's still evidence of good antibody production from it.
Cool. We can move on to the next one. Our next myth is if I take the vaccine, the cells of the COVID vaccine can alter my DNA.
I'm not gonna lie, this is kind of scary.
So I feel like we're kind of on a roll with our answers. And also I noticed this was something that was talked about a lot during the beginnings of like vaccinations. So Dr. Young, do you want to touch on this point?
Yeah, so absolutely what everyone is also saying, it's false. So I think this was all spurned from when the Moderna and the Pfizer were both developed because they were mRNA based. But if you go back to your basic biology course, it's a different genetic makeup with your amino acids. So if you actually have the basic 4 building blocks of DNA versus the RNA, you'll know it's very different. So it just helps code whatever protein they're supposed to develop. But once again, you can't really actually absorb the mRNA because the signaling and the whole transmission back to the biocellular level is completely different. So you won't really actually have an alteration in your DNA just because strictly from a structural standpoint, they're different. It's apples to oranges in this regard.
Makes sense.
I don't have to get the vaccine because if everyone else gets it, I will have herd immunity. So we got mainly falses, and I threw in a little curveball. I'm actually wondering this. I put true with question mark because of the word have to.
I feel like it's an interesting take on it. So I'm interested to hear what you have to say, Dr. Young.
Yeah, so this is kind of like a double-edged sword because we kind of have a more recent like correlation with the measles outbreak. So a very similar process too. So if you end up getting the vaccine, it helps prevent your immunocompromised, your very susceptible patients like your grandparents, your great grandparents from potentially contracting and developing the disease if they can't get the vaccine. So yes, absolutely, you don't have to because no matter what, it's your body, it's your free choice. So to answer Jeremy's question, sure, you don't have to because it's not like someone is going to force you to do it. The whole concept of herd immunity, we know it from previous experiences from previous pandemics and epidemics. But the only problem is since COVID is an entirely different beast, we actually don't even know what percentage is required to achieve the true herd immunity that we need to help be in a protective realm. We always go by 70%, but as we learned from COVID, nothing fits the mold with it. So it could be 90% before we reach any sort of like true population immunity. So no matter what, you getting it, if you're of mind able and capable of doing it, we encourage you just because you're protecting yourself too. Because we do see younger patients right now who are suffering from the disease from both the hospital and the outpatient side who are having lingering issues too. But yeah, tricky, very tricky.
All right, here's an interesting one. Some vaccines are better than others. So like Pfizer is better than Johnson & Johnson, etc. Seeing a lot of different answers. Many unsure, some saying true, depends. And then just like tough call, don't really know. So yeah. What are your thoughts on this one?
So this is the tricky part because this is like everyone's saying, there is some truth and some falsehood to it. So any vaccine is better than no vaccine. But if you look but if you're going to like true purity of it, if you want to go by efficacy, then that's where some people harp on, well, this is 95% versus 80%. So I'm going to go with the 95% efficacy one. And that's just a matter of how severe you develop the disease if you happen to contract it. So once again, it's not like it's preventing you from getting COVID. It just helps prevent the level of severity that if you get it. So 80% meaning 1 in 5 patients, if they happen to get COVID, they might get sicker. But it doesn't necessarily mean they're so severe that they wind up on the ventilator on the inpatient side. They might just have more respiratory based symptoms versus no symptoms at all. So from the falsehood side is just the idea that you are protected. You might develop some sort of mild or moderate symptoms, but it doesn't necessarily mean very severe. So for example, in my household, I have myself and my husband who have Pfizer, my mom and my brother who have Johnson and Johnson, and my sister-in-law who got Moderna. So at this point in time, it was one of those things where my mom's like, shouldn't I get the Pfizer one? I'm like, at this point, any vaccine is better than no vaccine. And once again, if you go across the world, people in other countries would kill to have the access we do to what we have. Just because the Sinovac, the AstraZeneca, their efficacies are anywhere as poor as 50% to 70%, which is the best one for AstraZeneca. So we have pretty much like the Ferrari or the Lamborghini of vaccines at our disposal that we don't use. And it'd be very, very, it's not shameful, but it would be terrible not to be able to use it because we have it.
If you get vaccinated, you can't get COVID. So I know you already talked a lot about this answer. And I think most people would now say false. So I can bring in another question that I personally had before is if you did get COVID and recovered, is there a certain period of time where you can't get the vaccine? Because I know you also have to get like booster shots periodically. I know for school, I might have to get another one right before I go to school. So is there such thing as like a period of time where you just can't get a vaccine?
So for now, we just go by the CDC or IDSA guidelines. So if you had COVID and you recover, they recommend waiting around 30 days before you get the vaccine. If you've had certain therapies like monoclonal antibody treatment in the inpatient side or convalescent plasma specifically, we worry more about the hyperinflammatory response you might generate from having predisposed antibodies already in your system. So it's just so that a way you don't over respond when you do get the vaccine. So we have patients normally wait the 30 days to get part one or just the Johnson and Johnson, depending upon which one they do get. So yeah, it's just more of a recommendations anywhere from 30 days to 90 days is the other one, specifically if you had the infusion therapies on the inpatient side.
Got it.
All right, I think that was our last myth on our list today. So I can stop sharing my screen, and I have seen a question pop up in the chat, and I'm just going to open the floor up for question and answers. We had some pre-submitted ones that we can go into as well. But I have a question from Josh here. What was the efficacy for Pfizer related to what we were just talking about with different vaccines?
Yeah. So Pfizer achieved roughly around a 95% efficacy. Moderna is around like, I think 90 to 92, and then Johnson Johnson's like around 80 to 83. So out of all of them, the most efficacious was Pfizer, but it's also one of the ones that had the highest, that's the one where you had to be in a high freezer, very, very sensitive temperature base. So there's something about the actual composition of the vaccine that is so brittle, but yet very effective too, from that standpoint. So that one from the mRNA, sorry, is that the one that, I see one from Aditya also. mRNA vaccines tend to have better efficacy since they are newer technology. If so, why? So this is the part where we're not entirely sure yet because this is the first type of vaccine of its kind. But the technology has actually already been around for around a decade or two from my knowledge, they've already been investigating mRNA-based vaccination or mRNA-based type therapies for at least over 2 decades. And it just happened to be in the last few years, our technology boom has also coincided at that point in time that allowed for the expedite production of the vaccine and for it to be able to be developed as quickly as possible. So, in terms of why it works a little bit better, it's probably just the idea that you take the genetic coding of the core of the virus itself to make a spike protein, and the protein itself is what our body is going to recognize to tell you that it is the same virus. And I was using this analogy earlier for like Mila and Jeremy is like, imagine a black widow spider. You know the black widow spider based on the red symbol on its belly. So if you were to take that red symbol specifically and make a type of vaccine or anything out of it, your body produces that red symbol, and next thing you know, it's going to attack that red symbol whenever it generates. So it's not you actually getting the virus itself, but you're producing something that's going to recognize something so unique to something that your body won't recognize anything else and respond to it. So that's why it works better than some of the other ones potentially right now, just because we use some of the other types of older coronaviruses to make our current vaccines, which is where I think the Novavax and I think Johnson Johnson have slightly lower, just because it relies on some of the older coronavirus vectors without giving them actually the COVID-19 coronavirus. So that's probably a little bit why the mRNA potentially works a little better. And it's also more brittle. Oh, how many protocols? A lot, a whole lot. But some good, definitely a lot of good changes have actually happened. So from the practice side, we're still engaging in masks. And that was the one biggest thing that I've noticed across the board is wearing masks and social distancing not only reduced our COVID admission rate and hospitalizations and illnesses, it actually significantly plummeted our other respiratory viruses too that we've noticed. Like we had very, very tiny incidents of flu during flu season, along with all of these other respiratory illnesses too. So if you have friends and family in school, notice I haven't had a cold in a month. Thank the masks and honestly social distancing. And so that's definitely helped a lot. Now, from the telehealth side, it actually boomed a lot too. And that's actually something we've been able to expand on where we can actually start seeing patients who live 2 hours away without actually having them to physically come in because it allowed us to do video chatting, etc. Granted, we can't physically examine them to see how they're breathing, if there's anything else, like if they're swelling or other signs and symptoms, but it has improved our reach overall where patients can actually at least get a hold of a physician to get the things, to get their examination and their visits started and then reconvene in person at a later time period. So we can do a lot more from that standpoint. And running out of inpatient space, absolutely. So Pittsburgh was lucky. We did not see the numbers that New York, California, Florida, Texas saw, but some of my friends who came out of New York, one of them specifically, my partner down in Jefferson right now, he was finishing up his last year fellowship in sleep, got pulled from his sleep training. And he said for 3 full months, a normal medical floor, not used to cardiac issues, not used to ventilators, not used to any like something as simple as you're just going in for an infected foot and needing antibiotics, to suddenly the nurses having to deal with a ventilator and hanging continuous drips, other medications to keep them sedated or to keep their blood pressure up in a matter of like an overnight. So those patients became flooded. They had patients in the hallways on the ventilator without their own rooms. And then suddenly for them, they just all died. And then it became a ghost town. And then next thing you know it, they started going back to normal operations because it was just a huge influx. So the things that we saw on CNN, MSNBC, Fox about those giant what's it called? The giant freezer trucks where a lot of the bodies went. He was actually at one of those hospitals and it was indeed where they went. So it wasn't centralized or anything or like over exaggerated like that. They had no space in the morgue anymore. So that is how severe it became at different hospitals.
Wanted to ask you, is there a like correct time period, let's say, like for like how long you should wait to get the second dose after you get the first dose? Because I know like here, for instance, like when I like me and my friend got the vaccine, you know, we had to wait like 2 weeks. But like all my family in India, like all my cousins, like both my grandparents and my cousins my age, they make them over there wait like a month and a half to like 2 months. And then I know in like my other cousins in Australia, it's different. So I didn't know if that was just based on like the way that like the different countries want to do it, or if there's like one time period that's like more effective than the other.
So I think it also depends on what they were getting too, because for the Pfizer and Moderna, we know that the most efficacious time period for the priming of the first and the second is going to vary from the 2 weeks, 2 to 3 weeks versus the 3 to 4 weeks. So in Australia and India, I'm not positive which ones they're getting. It could be because if they're a two-stepper, their second step is designated as like the 1 month or the 1.5 month mark, or it's also because of availability, because there are countries that were using the first or their second dose as a first dose and running out of enough of the second dose for people who needed the second dose when it came around. So it could be related more or less to a supply and versus demand. So they're just trying to get everyone to get the first dose, which you achieve a little bit of if you it was a Pfizer Moderna, you can get like a 50 to 60% efficacy, but the true maximum benefit's always with the second dose. So they might have already tried to just get at many people as possible with the supply that they receive just to get something instead of some people getting all of it and some people getting none. So it's hard to say if that's the reason why, just based on probably availability of the vaccine too.
I see Aditya put a question in the chat, which is actually something similar to what I've wondered previously.
Yeah.
And it's like, without the spread of viruses like the common cold, what are the long-term effects for our immune systems? And like sort of to add on to that question, it's like, I've heard a lot of talk of like babies who are born during COVID time, like not being exposed to these colds. Is that bad in the long run for their immunological development?
So it's going to be variable. It's pretty much like if you happen to never go to daycare or school in general as a kid, you go to elementary school and you get a brand new exposure to all the viruses. I know that happened to me because I was in a daycare growing up. And you'll see that it's just a matter of timing of when you get it. So your immune system, the nice part is no matter what, when you encounter, if it's just a common virus, it will fight it because it has the basic strong immune response that you'll always generate. So overall long-term effects, there shouldn't be any detriment to it at all, just because the common cold is going to be a slew of viruses. So every single time you get a cold, it's honestly probably just a different virus that you develop. We just don't know what, because we're limited in terms of identification capabilities. So just for example, for coronavirus in general, that family has hundreds of variants, with COVID being just one of the five that we are able to test for, that, or one of the seven that we are able to test for to cause human-based respiratory diseases. But there's hundreds upon hundreds of them available around that we just don't know yet. So it shouldn't affect your immune system. Just like, for example, every single year you get the flu shot, you can still get the flu, just because we know it just, you don't actually prevent getting the virus, you can still develop it. So it helps your immune system develop the antibodies and helps get it stronger, sure, but it's meant to kind of just be for that specific type of virus too. But overall, just normal, healthy lifestyle living, etc., normal exposures is all you really need for your basic development. I think there's another one. Does the vaccine protect you from the Delta variant? So we don't know enough about that quite yet, because the Delta variant just started becoming recognized within the last few weeks itself. So the concern is that the new variants might decrease the efficacy of the antibodies that you actually have from the vaccine itself. But if you do develop the Delta variant, granted it's more transmissible, we're hoping that if you do develop it, you have more of like the potential mild to moderate, but not the severe symptom realm. Like to this date, we have yet to see a patient come in like dog sick who has been vaccinated. Everyone we see that's gone so severe have not been vaccinated. And I think that's what's been witnessed across the board with the Delta variant too. Like so far, everyone coming through the doors in the hospital setting, if they do have the Delta, it's because they did not get vaccinated yet.
We also have a few questions that were submitted along with some registration for this event. So one of those is it true that if you are vaccinated, it's safe to not wear your mask outside?
So Yes, because you're no longer needing. So the idea is, yes, it's safe because you yourself won't develop the serious symptoms, but and this is kind of like the difficult part was there's a possibility, not saying it's completely true or false, that you could potentially be a carrier for it. It's just when you do care, if you do become a carrier, it's very, very truncated, but you still potentially could transmit it to somebody who has not yet been vaccinated. Because once again, you won't know you have it because you probably won't even develop the symptoms since you got the vaccine. So if you are around people who have delicate immune systems who can't get the vaccine, there is still a potential that they could develop it. We actually have a patient, it was actually a very sad case, where she got part one of the vaccine and she was due to get part two a couple of days before she got sick because her kids ended up having COVID and gave it to her, and she ended up passing away from complications 3 months, like 3 weeks afterwards. So it's one of those things where you have to be ridiculously cautious and just be more aware and in tune of like who you're going to be around with. That's why when they're like, oh, people can be in gatherings if they're vaccinated, it's great. But if you go home and you have a loved one who's like a child or anything else, you would still have to be a bit careful.
We also have a question about your personal experience as a doctor, which is something you touched on at the beginning of your presentation. And so these sort of go hand in hand, but one is what prompted you to become a pulmonologist, and how has work changed ever since you had to start treating patients with COVID in the hospital, and like what are some challenges that have come along with that?
So I got interested in pulmonary. Well, it was actually kind of weird because I initially wanted to be a surgeon. I was a live hard, die hard, wanted to be a surgeon ever since I could remember when I decided I wanted to be something whenever I grew up. But as I started rotating through it, I realized life is an open book. And just because you set your mind to something doesn't necessarily mean it's what you're going to actually fall in love with. So I fell in love with internal medicine first. And when I started to expand around, I love the physiology of both the kidneys and the lungs, oddly enough. But when I started rotating through the lung side and seeing the true spectrum of just lung diseases, not just in the hospital setting, it became something that was just so fascinating to me. And then if you add on the ICU side too, because most programs now are combined pulmonary and critical care, there was just nothing that could touch it in terms of like what actually made me happy going home. So I think for no matter what career path that you choose, the most important take home is if you can go home excited what you did for the day and be overly excited with what's going to happen tomorrow, then you found the right profession. And I think that's the biggest thing is like no matter how tired you are or how stressful your life is, if you can go home and just feel some sort of fulfillment, then you found the right career path for you. Now, having said that, COVID has definitely put that statement to the test significantly still this last year and a half. And I think the biggest thing is because it wasn't the frustration of the disease, but it was more or less the slight sense of hopelessness just because of how we were seeing these patients like develop. Because it wasn't, I think the best way to put it is we know what we're supposed to do for certain diseases. If you develop respiratory failure, you give them breathing tube, they either get better or they don't. But most patients show some sort of progress and there's some sort of algorithm. So, but COVID literally demolished anything and everything in terms of what we thought we knew with how to manage patients. Because we've had patients who did remarkably well for the first like week or so, but then suddenly tank and get worse all suddenly. So it was just a very frustrating and mind-boggling year and a half. We start now reflecting back a lot of things that we did. It's like, did we do the same too? And my trainees, did we do the right thing at this point in time? Because what we did back in March of 2020 is very different from what we do now, March of 2021. So management has changed and evolved. And granted, even though we understand more about the virus, the pathology and the physiology of what the virus does is still so different from patient to patient. So it's a very different spectrum from what we're used to. So COVID, if anything, made it more challenging. And I saw a lot of my, not necessarily my partners, but at least the trainees get burned out much faster just because it became such a higher demand in terms of just mental strength and emotional strength than what we were used to even before. So I think that was why. But now that it's calmed down, I'm not gonna lie, just seeing a simple patient with liver failure brings a shine or like a twinkle to my eye again, just because we're finally seeing our usuals and we're seeing less of the COVID. We're still seeing some COVID, but it's definitely not like what it was, because it came in waves and we just didn't know what to do or how to handle it. And I think that was the scary part, is just the unknown that was happening with this.
Yeah, thank you for sharing.
Yeah. Of course.
I think we can take one more question from Josh in the chat. If I get the vaccine and I don't wear a mask outside and I happen to transmit the truncated virus to a child who isn't vaccinated, will they get the weaker version of the virus, or will it just be the normal COVID-19 virus?
So the virus itself won't be truncated. It just means that your body happened to resolve it or attack it and respond to it faster, but your child will still get the full virus. So I think that's the biggest concern. I think that's a misconception, is if you get COVID-19, you're not getting like a Cliff Notes version of COVID-19. Your symptoms will just be shortened because you happen to be protected. Your child, though, will get the full blunt of the COVID-19 too. So that's where you might see them. And with kids, there's actually an interesting fact, that the fact that they're so resilient, there's something about their immune system that we see less severe cases, but it still does happen. So they might still have a little bit of the same symptoms, runny nose, cough, fever, and be okay. But they might be even the more extreme that we've seen, where they have very high fevers to like the 104, 105s, and they have this like hyperinflammatory state also that we've been noticing in our children's hospital setting. So you won't really get a truncated, you'll get the full COVID from transmitted to your child too.
Sweet. Thank you so much for taking all those questions,
Yeah, of
and
course.
also like answering the myths and giving your presentation. Like, we really enjoyed that. I just wanted to remind everybody that this will be recorded and it will be posted on our Care for Them YouTube channel. And in case anybody, yeah.
You guys have a YouTube? Oh dear.
Yeah, it's actually funny. So I'm about to remind everybody like how to find us. So our name is like Care for Them. You can Google Care for Them, all one word, and our website is the first thing that pops up. We also have a LinkedIn, a YouTube, and Instagram, and we're working on expanding that social media platform. But this video is going to be posted up there, maybe edited. We might want to insert some things here and there, but we'll see. And thanks again. Yeah. Is there a part where if anybody has any questions, do you have a spot where they can kind of find you and ask them?
Oh yeah. Let me just type in my email there. So I have a Gmail. I'd send you my work email, but it's probably gonna go to my spam. So easiest is gonna be my Gmail. So it's just my first and last name with a period in between at Gmail. So if you have any questions, non-COVID related, medical, life decisions, career paths, even shadowing, whatever, feel free to send me an email. I'll see whatever I can do to help.
Sweet. Thank you so much.
Of course.
Just on behalf of all of Care for Them and everyone here, thank you so much for being here. And this was a really valuable presentation and an event.
For having me.
Yeah, thank you so much.
Thank you, Dr. Young.
Thank you so much.
Thank you.
Okay. The pleasure. Take care, guys.
You too.
You as well.